Good day, everyone. Thank you for inviting me to this Congress. I am Dr. Medaille, presenting a not very common procedure in Spain, the sutureless manual small incision cataract surgery, or M6 for short. You might have heard of M6. It's a type of cataract surgery, probably a subtype of ECCE, but has the advantages of phaco, fast mobilization of the patient, less astigmatism induced, and early visual recovery. It is low cost and very good for high volume areas, such as those in developing countries. This table compares M6 and phaco. Phaco incisions are much smaller than that of M6, but their surgical times are actually quite similar. Phaco has the advantage of foldable lenses used, but the turnover rate for M6 is actually faster compared to phaco. The cost as well is much less for phaco regarding surgical supplies. And M6 is actually quite ideal for hard or mature cataracts. To show an example, we present a case of a 65-year-old male who had BOV on the right eye over 2 years. History was unremarkable. He had a VA of zero point zero 0.05 and a cataract of around grade 5, NO5 and C5, with against the rule astigmatism of 0.50 at axis 96. Everything else was normal. We planned an M6 procedure for this patient. As you will see, we had already dilated the patient prior to the OR with topical phenylephrine plus tropicamide. Subconjunctival injection of lidocaine and epinephrine was done. Then we created a conjunctival flap, specifically this way, with good hemostasis. Then, 1.5 millimeters behind the temporal limbus, a 7 mm frown incision is done for the scleral tunnel. This tunnel is 3 mm lengthwise towards the cornea, done with the crescent blade, but no penetration into the anterior chamber yet. Side incisions are made, trypan blue is applied, and then washed. Then viscoelastic is injected, especially to protect the endothelium. A capsulorhexis was done, albeit larger, 5.75 to 6 mm, to decrease zonular stress and ease of luxation of the cataract later on. Hydrodissection and rotation of the lens is done before enlarging the main incision. The main stab incision is then enlarged following the previous crescent blade plane. After applying viscoelastic to protect the endothelium, the lens is prolapsed into the AC, into the trapezoidal wound to maintain the seal, and finally the delivery is done. INA is completed. Then we insert the rigid PMMA and we center it. And the viscoelastic is hydrated out as well as aspirated. Due to the wound geometry, size, and design, no sutures are needed. On day one post-op, our patient from a vision of 0.05 now had an uncorrected vision of 0.6 with the refraction of minus 0.25 and 0.50 axis 180. He had a corrected vision of zero point 0.8. This was probably due to the minimal corneal haze that he had and minimal DM folds, but everything else was normal. On day 30, however, his corrected vision was already 100%, still with the same astigmatism. And as you can see, compared to before, there was a change in the axis. Now he is with the rule, probably because of our temporal incision, which was 7 millimeters long. We have just shown you a pretty successful case of M6. But then you may ask, what are some issues with M6? Visual outcomes? From studies, it has shown that the BCVA of phaco and M6 are actually similar. But phaco had better UCVA, especially in the short term. Astigmatism, they were also not significantly different. But we think that these cases probably had smaller incisions than we had, which, if you remember, ours was 7 mm. Endothelial damage, the EC loss among ECCE, phaco, and M6 were comparable. And finally, for endophthalmitis rates, there were no great differences. In conclusion, M6 is actually a very viable method for cataract extraction, especially in developing countries
or for patients with financial issues. The advantages: costs, safety, surgery time, and effectiveness.
These are my references.
Gracias por su atención.